Dr. Tom Weber, he is the director of the Orofacial Pain Clinic at Eglin Air Force Base in Florida. He completed his residency in orofacial pain at the University of Kentucky, and really just an all-around great guy. Please.
All right, now we're in business. Well, my name's Tom Weber. It's a pleasure to be with you. It's an honor to get to speak. Now, maybe Mariona or Sherwin already asked this question, but just so I know who I'm talking to, how many of you are already practicing in orofacial pain? Okay, so there's a few of you. All right, and what are the rest of y'all doing with your lives? We got general dentistry going, or physical therapy, or how many general dentists do we got? All right, awesome. You guys just here because you're interested? Oh man, it's so good to have people interested in this. We need more people interested in orofacial pain. So, let's talk a little bit more. Sherwin gave a great introduction to anatomy and so forth. So some of you who are already practicing in this realm, this may not be anything particularly new for you. We're just going to talk about doing a history and an exam, which of course is really important, right? When we're talking about orofacial pain, this becomes a lot different from more traditional general dentistry, right? In general dentistry, of course, diagnosis is extremely important. We want to have a diagnosis. We don't want to go in and treat the wrong tooth or the wrong condition, but the lion's share of your energy, time, and effort are going to be spent procedurally, right? When we transition into orofacial pain, suddenly this is a different animal, especially when we're talking about people with chronic pain. Now, all of a sudden, our energy, time, and effort are spent much more on understanding the condition, diagnosis, and sleuthing out that diagnosis and the contributing factors. Well, that requires that we get a good history and an exam. The most powerful tools we've got in orofacial pain are your eyes, your brain, and your hands, right? So everybody in orofacial pain probably does this history and exam a little bit differently. There's a lot of different flavors out there. Some of you who are already practicing in this realm, you might have your own way of doing it. So if you got any other ideas, feel free to toss them out there. But I'll share with you my perspective on it. Now, as mentioned, I am active duty Air Force, but just so you know, I am not here as an official government spokesperson. This is just my own thing here, so don't take it as the official policy of the Department of Defense, okay? Here's your first quiz of the morning. You guys ready for a good quiz? I can tell you are. All right, somebody's going to know where this quote comes from. Life is pain, Highness. Anyone who says differently is selling something. All right, where does this quote come from? Okay, hint. From a movie, from one of the few perfect movies that's ever been made in this world. Nobody knows? Somebody knows. Say again? A better hint than that. Think about piracy. Okay. Oh, what a good guess. It's actually not Pirates of the Caribbean. Is it Caribbean or Caribbean? I always say Caribbean except when you're at Disney, then it's Caribbean, right? So, and by the way, Sherwin's thing about getting, some hemifacial paresis, that's the best. When you put the eye patch on, you just got to let your patients know, if you can't blink, we're going to put a patch on you and you have to talk like a pirate until it comes back, all right? So this quote comes from The Princess Bride. All right, who has not seen The Princess Bride? Just fess up. Confess it. All right, you guys are all a bunch of liars. You, sir, are a brave and honest man. All right, homework. Got to go see The Princess Bride. If you haven't seen this movie yet, this is a good one. Next one. Do we have anyone with us today from the United Kingdom of Great Britain and Northern Ireland? Oh, wonderful.
Actually, I'm originally from Thailand, but I'm studying in London, so I feel from
We're going to count it. So will you read that quote loud and proud for us, please? Please, by all means. Very well done. What's your name, ma'am? Pon. Thank you, Pon. All right. Who knows where this comes from? I'll give you a really good hint. Think the very first name that comes to mind when you think English writer. Who is it? Shakespeare! Yes, sir. This comes from the play Much Ado About Nothing. And then finally, probably the most difficult one. The greatest evil is physical pain. That's a quote that's attributed to the Venerable Saint Augustine. So let's shift into the pain world and talk for a minute about how to do a history and an exam in the world of orofacial pain. Dr. Weldon Bell, an oral surgeon who I believe had something to do with coining the term temporomandibular disorder, he said this: the first goal is to establish a specific diagnosis. When an accurate diagnosis is made, the correct treatment often becomes apparent. So let's get a diagnosis. We're going to do that with a history and an exam, possibly some imaging, possibly some additional labs, okay? But how to get a history? Well, how do you do this? You can just talk to the patient. You can have them fill out a questionnaire. Pretty much everybody that I know practicing in this area, excuse me, is doing a combination of the two. Some have lengthy questionnaires, others brief questionnaires, and they just know they're going to get more from their interview. You find the balance that works for you. Now, when you're interviewing a patient, it's important to be somewhat open. You want to let these people have an opportunity to speak. One of the luxuries that I have in my practice is the luxury of time. You know, particularly with a chronic pain patient, to let them feel like they really have an opportunity to fully explain what they're experiencing. That is really valuable. When you look at some of our primary care physician colleagues who are wonderful, super intelligent, hardworking, diligent people, many times they are very limited. I know at my installation they get about 20 minutes to do a patient interaction, and that includes, you know, reviewing a note that's got about 10 pages of crap in it that they don't need. I mean, I don't know how those guys get anything done. So taking a little time and being open, but directed, right? The directed thing, there it can be really helpful to have a set form that you follow. Otherwise, with some of these patients, it's really easy to kind of go way off into the weeds. And sometimes you just got to do that. You got to be gentle and just bring them back, just like that. Active listening, right? So when you step into the room with these patients, you don't want to have the traditional dentist, on goes my mask, unless you're still in a COVID-restricted area, right? Mask, glasses, gloves, we're ready to dive in and do a procedure. No, you want to be looking that patient right in the eye, letting them know you are following every word that they say. Again, using a form is helpful, and one that's a little bit easy to get trapped in is leading questions, right? If you have a feel for, or you think you know what this diagnosis is going to be, you're pretty sure it's a TMJ, and you push on that, and it's like, it hurts there, right? Doesn't it hurt there? And the patient will probably be like, oh yeah, it kind of does hurt there. And try not to lead them along. Let them give you the answers. Now, sometimes when you ask a question, you'll get back a response that is completely surprising. Like this one time I did a Google search for lateral pterygoid spasm, and I got back this nice map showing the distribution of the koala population. So you'll get similar experiences with some of your patients. You may ask a question, and the answer you get seems utterly tangential at best, and you may just have to, again, do the gentle nudge, return and redirect. What do we want to know in a history? Well, we certainly want to know about their medical history. That old cliche about never treat a stranger definitely applies, right? We got to thoroughly know their medical history, including what medications they're taking, dosages and frequency and so forth. Well, their dental history, complaints, behavioral and psychosocial factors, all important aspects of a history. So as far as a medical history goes, it's an interesting thing that in my experience, there are a couple of things that people, for whatever reason, just don't seem to consider to be part of their medical history. Sleep apnea is one. You might have to sleuth that one out. Sleep apnea, sleep factors, really important with assessing pain patients, especially the chronic pain folks, right? But, you know, you can ask, and sometimes, I mean, in the Air Force, we have this medical history form, the AF 696, right? At least that's what it used to be. Now we have a big mess, but because of the system we switched to. But anyway, there's a question on there. Has anyone ever seen you stop breathing or gasp for air or blah, 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 blah? People will check no on that and then come to find out, oh, they have sleep apnea. So you got to sleuth this one out a little bit. The other one people often will not report is headaches. Person might be getting 2, 3 migraines a week. They won't report it. So these are things that are good to ask about specifically. Other body pain. This is a big one too, right? If you get the person who has pain and it's just right here, that's probably going to be a different situation and a different approach than someone who has pain in all of these places. Family history can be an important factor, especially when we're looking at things like headaches. Anybody else in your family get headaches or head pain or face pain? History of trauma, yep, that can be a definitely precipitating factor, right? Surgeries, medications, as we mentioned. As far as dental goes, of course, we want to make sure we don't forget our good foundation of regular old dental stuff, right? I mean, what's the most common orofacial pain? Odontogenic, the toothache, right? Toothaches, periodontal pains. Those are the most common orofacial pains. So let's make sure they don't have some underlying thing in that realm. Treatments in relationship to onset. Now, this one you gotta watch out for a little bit, because you can ask them, when did your pain start? And get an answer, it started after I had braces, or it started after I had my wisdom teeth taken out. When you ask, well, how long after that? Oh, maybe a year. Maybe that's not such a tight connection, right? I think the human mind just naturally wants to look for some causative explanation, and sometimes we latch onto things that may not be causally associated. There's the classic story that you have all heard. We got any oral surgeons in the room? Not yet? All right. But the classic story of the oral surgeon who put his foot on my chest. Have you guys all heard about that surgeon before? Yeah, the oral surgeon, it was such a rough extraction. He put his foot on my chest to get the tooth out. So somewhere in these United States, there's like one oral surgeon who's sticking his foot on people's chest. So we got to find that guy and get him to stop. Okay? But sometimes dental can play a role. And so it is good to be aware of that possibility. Now, when we're assessing the patient's complaint, if you have a form to guide you, you won't forget the aspects of the chief complaint that you want to investigate. But let's say the computer goes down or the printer's out of ink, you don't have the form, something's happened, and you got somebody showing up in your chair with a pain complaint. What do you want to know? So I've tried over the years to come up with some handy mnemonic, like you remember the old cranial nerves mnemonics on Old Olympus Towering Top, or some other probably less appropriate ones that people have come up with. But with this one, this is the best I can do. So if y'all got something better, you tell me and you win a prize at the end, okay? But lift pain at a dock. That's the little mnemonic I came up with to help myself remember what aspects of a chief complaint do we want to know. Now, I don't necessarily ask about them in this order, but here's what we got. One of those I kind of cheated on. I needed an N, so I came up with number of complaints. But that's just to remember, people can have more than one problem, more than one diagnosis often fits the situation. To look briefly at each of these, location. When you do this, have them point or outline with a finger the area of the pain. So patients are great. They're smart people, but they don't have your training. They don't have your understanding of anatomy. And it's been more than once that a patient has said to me, hey, so where's the pain? Well, the pain's in the joint, doc. It's right here in the joint. So make sure they actually point. If they say they've got, and so many of them will, right? They're going to tell you, I've got TMJ, right? I got TMJ. What does that mean? I don't know. Let's find out what it actually means. The reaction you probably don't want to do is well, actually, you have 2 TMJs, right? And you can provide them some education, but you want to be nice about it. Have them point. Character, quality. This can be a helpful guide as to what the source of the pain might be. When we're looking at these types of different pain, we have things like neuropathic pains, musculoskeletal pains. A neurovascular pain would be headache disorders, things like migraine or cluster headache or related headaches like that. Well, looking at that top category, dull, aching, pressure, tight, stiff, what category do you think best fits that? Sounds like musculoskeletal, right? If we're looking at the bottom, electric, shooting, cutting, itching, maybe other weird sensations, dysesthesia sensations like crawling or just unpleasant sensations. Does that sound like a temporal mandibular disorder? It does not. Might be a different kind of orofacial pain. What kind of pain category does that sound like? Sounds like a nerve pain, right? This sounds probably neuropathic. So we got probably musculoskeletal there. If we're throbby, stabby, pounding, rhythmic, that might be a headache disorder. And then that other stuff, maybe a neuropathic pain. And some of you have, probably everybody in here has encountered a neuropathic pain at some point. I mean, the classic example of this would be trigeminal neuralgia, right? Where somebody gets these shooting, horrible lightning bolt stabbing pains that just zap through one or more of the trigeminal nerve divisions, and often is accompanied by a lower level continuous background pain. But there's plenty of other neuropathic pains out there that can happen. Toothaches, the neuropathic toothaches essentially. So we want to be alert to that possibility as well as to the more common and more traditional TMDs. Intensity, the easiest thing is to use the numerical rating scale. Those visual analog scales like you see on top are used in research a lot. To my mind, it's not really practical. The easiest thing is just 0 to 10, right? It's good old 0 to 10. If it's an adult patient, they're going to not usually have too much trouble understanding that. But I do find it's helpful to stress to them that this is just your personal 0 to 10 scale. This is not intended to compare you to anyone else. What almost, I would guess, 95% of your patients will tell you is the following quote: I have a high tolerance for pain. And so they'll kind of put their numbers down, like, so for me it's like a 4, but most people would be like an 8. So just stress them, this is just your own personal, 0 to 10. Frequency and duration. So some pains are just there all the time. They're just constant, continuous, unrelenting. Others are intermittent. So if it is an off and on intermittent pain, then how often does it happen? Is this multiple times a day, once a month, once a week? And how long do those episodes last? Triggers. If they're in a pain-free state, if it is an intermittent pain, what takes them from off to on? And that could be all kinds of things. So again, jaw function. How about aromas? Well, an aroma triggering a pain, what kind of pain does that lead you to suspect might be in the picture? I mean, maybe one of these neurovascular things. Migraine, right? We have any migraine sufferers in the room? Yeah, not fun. Triggers probably, identify things that kick those off. For some people, it's aromas, foods, bad night's sleep, stress, maybe pain from other body areas like TMD pain. Light touch, well, that could be a trigger. Well, what kind of pain might be triggered by light touch? Well, again, we've got our classic trigeminal neuralgia example. Some neuropathic pains will be incited by things like that. Onset, in the beginning, the very first time this happened, right? When did it start? How long ago did it start? And were there any particular circumstances precipitating that? Life circumstances, traumatic events, anything like that? Aggravators, those would be things that once the pain has started, what makes it worse? Often those are similar or the same as the triggering factors. And then alleviators, does anything make it better? Reduce or eliminate the pain? As far as time pattern, there are a couple of ways we can think about that. One would be on a daily basis. So is there any consistent daily pattern? Does it tend to be worse in the morning or in the evening? You'll find with muscle pain, myofascial pain, about 80% of patients have worse pain in the evening. Okay. Many times I think traditionally dentistry has focused really heavily on, you got pain, sleep bruxism, bite guard. It ain't necessarily so, right? A lot of times it's more the daytime function that is more important than what's going on while the patient's asleep. And then the other one could be on is there any circannual rhythm to this? Does this pain occur at any particular time of year? We see that with certain types of headaches. Over the long haul, is it getting worse? Is it getting better? Or is it just cruising along, just plateauing? Associated symptoms could be, again, all kinds of things. Does anything else happen when this complaint occurs or when it gets worse? Limited jaw function, or perhaps even neurological disturbances, visual disturbances, as we see with some migraine sufferers. Autonomic symptoms like conjunctival injection, tearing, congestion, rhinorrhea, all skin flushing, sweating, all of those kind of things could be in the picture. Impact. How big of a deal is this? Is the patient kind of managing it okay? If they're coming to see you, maybe not so much, right? Is this making a real significant impact on the patient's quality of life? And then what's been done in the past? What's been tried to treat this? Behavioral interventions, medications, bite guards, right? Occlusal appliances, and if so, how well did they comply with that recommendation? Did they take Flexeril for 2 nights and call it good? Well, maybe not an adequate trial of a medication, right? So those are our lift pain at a dock characteristics. Now, other things that are important to know. Now, parafunction. Parafunction could be in a lot of different senses, right? Again, we often typically think of sleep bruxism, but how about during the day? Is the patient, say, gritting their teeth, clenching, tensing? You know, you don't have to necessarily put your teeth together to clench. It's like an oral surgeon in my clinic says, you can do like the cat face thing, like this, and tense your jaw muscles up. Is the person doing that when they're stressed, concentrating? If they're driving, especially if they're driving in San Antonio. Anybody here live in San Antonio? If you go there, take an extra driver's safety course, okay? How about at the gym? We got a lot of gym rats in the military, right? Guys are in there pumping iron, doing like, doing this kind of thing, because it makes you stronger when you grit your teeth and you lift. Did you know that? It makes your muscles bigger. Sleep factors, nutrition, substance use. Is the patient consuming caffeine, alcohol? What's the frequency, of that? What times a day are they consuming that? Tobacco use. And then psychosocial factors. In addition to the oral habits, other parafunctional things could be work-related. Sherwin talked about the sternocleidomastoid. Is the person at work, are they hunched over a computer like this all day, like I am at this microphone up here? Are they holding the phone, with that old thing where you do this and hold the phone between your ear? How about sleep again? Now, we've got a lot of different instruments that could help us assess sleep, right? We've got the Epworth scale, that Epworth sleepiness scale. We've got the stop-bang, kind of a screening for sleep apnea. There are other things out there like the Pittsburgh Sleep Quality Index. You can look at these questionnaires and see, what might be helpful for you to have your patients fill out as part of their intake forms. Some specific sleep factors I think are helpful. Well, I'll say real quick, the relationship between sleep and pain is interesting because you can see how this is bidirectional. You've got classic examples of people with shoulder pain, back pain. Those pains make it more difficult to sleep. They wake them up and disturb their sleep at night. And so pain can be an adverse factor impacting sleep. But the relationship is also true in the other direction. Sleep makes pain worse. We see evidence for that specifically with TMD. Part of the OPERA study that was done a few years ago following over time individuals who began pain-free, but then following and see who develops TMD. And in individuals who develop both sleep problems and TMD problems, the sleep problems tend to develop first, suggesting that's a predisposing factor. So the relationship is bidirectional, but it's actually stronger in the evidence as far as sleep to pain, meaning that bad sleep is a stronger predictor of pain than pain is of poor sleep. So in addition to those questionnaires, we might want to know how long does it take the patient to fall asleep? How much sleep do they get, and is it interrupted or do they sleep pretty solid? Do they snore? Are there any witnessed apneic events? Are they doing that in the middle of the night, right? How do they feel when they wake up? Do they feel refreshed? Now, that might not mean that they're jumping out of bed ready to sing the sound of music, but do they feel pretty good getting up? Or are they just hitting the alarm over and over again, right? Let's get through that. Nutrition, are they staying well hydrated? Do they skip meals? Are they experiencing unintended weight changes? We mentioned substance use already. And then with psychological factors, there are also some screening instruments that can be helpful with this. The PHQ-4 is a very brief screener for anxiety and depression that some of you may have encountered. That can be helpful. Looking at PTSD, there are other forms like the PCL-5 that screen for PTSD. Of course, in our profession, where unless you have a dual background in psychology or psychiatry, you're probably not going to be intervening extensively directly. You might be helping the patient to do some relaxation routines, diaphragmatic breathing, physical self-regulation. These are certainly within our realm to introduce if we feel those will be helpful for a patient. But these might help you recognize when a patient needs further mental or behavioral health intervention. Sometimes one of the most valuable services that we can do is to recognize and refer. Recognition and referral is a great service to do for patients, and that includes the psychiatric and psychological realms. And then I think it can be helpful to just ask the patient a few questions. Is there anything else I should know? Give them a moment to just Share anything else that they feel you may have missed in this interview. What do you think is going on? It's interesting to hear, does the patient have an idea of what this might be? Sometimes they're very insightful about that. Sometimes individuals might have some ideas, some biomedical ideas that don't necessarily comport with a modern understanding of medicine that they've adopted for any of a variety of reasons. And it can be helpful also to recognize that. That might mean you're approaching the problem or the conversation in a bit of a different way. And then what do you expect from your visit today? The answer that I love to get, and I sometimes do get it, is, Doc, I just want to understand what's going on. Or, I want to know what I can do to help this get better. I love that answer. The answer I don't like as much is, Doc, I want you to fix me. And there we may need to have a little more of a conversation about expectations, right? Wouldn't it be great if we could just fix people? That's one of the great things about general dentistry. You see a hole and you plug it, Endo, great. Whoosh. There we go. Problem fixed. Pain, doesn't often work out that way. So one of the best things we can do is build a patient's self-efficacy. Help them develop that sense that they are not simply at the mercy of these horrible forces. They have a measure of control. And maybe they're going to have pain. But if they can learn how to live, to function well, even with a measure of pain, hey, they can still have a great life. They don't have to be the slave to their pain, right? My Air Force friend in the back, where are you stationed? MPDS. Oh, are you in the program up there? Man, oh man. Lindsay, first name, is that right? All right. Nice to see you in person. What year are you in now? Awesome. All right, glad you could all meet Dr. Cunningham. You see, she's active duty Air Force. She's one of my peeps. It's always good to see a fellow person in uniform. I'm not in uniform now, but I am in my heart. Okay. All right, an exam. So we've done an interview. Let's do an exam. Now, the normal dental world, an exam is going to be the objective data, right? Whereas the interview is more subjective. With an exam in orofacial pain, there's definitely some subjectivity here too, because you do have to rely on the patient. It's not like we've got a pain detector, right? I mean, those little ultrasound things Sherwin was showing, they look pretty cool, but we don't have something that you can just run over a patient and beep, 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 there's the pain, go get it, right? It'd be great, but we don't have that yet. So we have to rely on them to tell us when something hurts, where it hurts. And, for the most part, we got to believe them. We got to get the information from the patient. One of the things in our realm, you don't need a lot of stuff. Again, brain, eyes, hands, those are the basics. It's a lot more simple of a setup than setting up for, endo retreat or pros or something like that. So now, I don't do all of this stuff with every patient. If somebody comes in and they're worried because they started having a click, or they just have a real obvious acute TMJ pain, well, I'm probably not going to have to do this whole shebang. But if somebody comes in with long-standing chronic pain, debilitating pain, multidimensional pain, then we might be doing the whole comprehensive orofacial pain exam. And if I don't have the time, I might do a quick exam and reappoint them, get them back to spend more time. But if I'm going to do the whole shebang, what are we going to do? Well, we can do first some quick screenings of overall physical appearance, right? Do they look basically normal? Symmetry, function, posture. You can have them do some simple tests of balance and coordination. You could have them, do the whole walk the line thing. You can have them close their eyes, see if they can maintain their balance. I did pretty good. You can have them, do the hold your fingers up, close your eyes, touch the finger to the tip of the nose, How about a cranial nerve screening? So, yes, we'll do a cranial nerve screening. Now, I'm not a neurologist, and I'm not pretending to be, but I'm looking for gross abnormalities, something that would signal to me something's off. This person needs further medical evaluation or a referral to our neurology colleagues. So we're going to do the KISS principle, keep it simple, Steve, when it comes to cranial nerve screening. So if you're going to screen olfactory function, well, you can do that test of have them close their eyes, cover a nostril at a time, have them smell something, coffee, a menthol, a mint smell. Typically, I'll just ask them, have they had any deficits or changes in their sense of smell? Same with vision. You could do all kinds of vision tests. Pull out the optometry chart. Can you read the bottom line there for me, please, Pan? Just kidding. Don't have to do it. She could do it, though. But, this is one where I typically will just ask them. Are they having visual deficits or changes in their vision? How about our ocular and optic functions? So, with this, we can do that pupillary light reflex, right? You can shine a light in the eye. If you have a little flashlight, a pen light, an otoscope, then, of course, what should you see? Symmetrical constriction and dilation of the pupils, right? Looking at the extraocular muscles, I'll just have them usually do this. The old, look at my finger without moving your head, just follow this finger with your eyes. Or, oh, moving the head, you're cheating. And they will usually come in closer, right? Not like this, and you should see them go a little bit cross-eyed as that finger comes in close. How about trigeminal function? So with trigeminal function, we got, of course, a couple different ways. We got our sensory and our motor. Sensory, it's pretty easy to just take your fingers, or I like to use Q-tips, right? Just brush through the three trigeminal divisions. Do we have symmetry? I'll usually also check the upper cervical nerves, right? Angle of the mandible, we know that's not trigeminal, that's upper cervical. Same with the back of the head, the occipital nerve distributions. If you want to test small versus large fiber discrimination, you can have them close their eyes, you can break the Q-tip in half, you can do the little pokey test with the sharp end, and then use the cotton end and just say, is that dull or sharp? Say, can they distinguish between the two? For trigeminal motor function, pretty easy to just put your fingers here, have them clench down. Right? Can we feel relatively symmetrical contraction here and up here in the temporalis? Facial nerve, here's where we get to go back to the border molding movements, like we're making dentures the way my old prosthodontists in Indiana University like to do it. Maybe whip out a little polysulfide and stroke it up just for the good old times. I'd have them raise their eyebrows up, right? Maybe puff out their cheeks, suck them in, do that fishy face, smile, show the bottom teeth. All that kind of facial nerve. Do we see both sides moving? Does this look pretty symmetrical? Vestibulocochlear. This one is easy to test hearing. You could do some more intensive testing with this, a Weber test or a Rennie test. An easy one to do is just rub the fingers together. We kind of stand behind them where they can't see you. Can they hear it on both sides? If you want to get a little more rigorous, you could do this where you move your hand away and the sound should go away at about the same time on each side. How about 9 and 10? Say aw, right? Aw. Do we see symmetrical palatal elevation? Some folks like to test the gag reflex. I used to do that just by taking a mirror handle and poking around back there. Honestly, I stopped doing it because unless there's some special reason to check it, people have such a wide variety of responses to that. With some people, you can take your mirror handle and you can just play around with their uvula and they don't even care. And other people, as soon as you get past the teeth, they already start retching, right? So a lot of individual variability. Accessory nerve, we're looking at muscles like trapezius, sternocleidomastoid, motor innervation, right? Put your hands on their shoulders, shrug up. Do you feel symmetrical resistance? Have them rotate or tilt the head. Same thing. And then hypoglossal, just have them stick out their tongue, straight each side. Cervical exam. How do they look when they're sitting there in your chair? Are they sitting, nice and straight, ears over shoulders? Are they slumped like this? Are their head off to the side like this? How about cervical movements? So here we'll have them go through extension and flexion, and then some lateral tilt or side bending, and then just rotational movements each direction. And there are some numbers here, as you can see, for what we would expect to see in normal range of motion. But maybe even more useful than that is symmetry. Do we see roughly symmetrical movement, or are they restricted one side versus the other? Now, as we're doing these, useful to ask, as they do those movements, is there any pain? Let them know beforehand. If there's pain, let me know. Now, if there is pain, what else are we going to want to know in that moment? Well, we're going to want to know where the pain is. Right at the moment, we're not palpating them. So if they're hurting, ask them to point to where it is. And the second question I think is always valuable to ask whenever a patient reports pain, is that familiar? Is that your pain? Is that why you came to see me today, right? Now, palpation, Sherwin talked about a little bit. Here's kind of the classic palpation exam as it has been handed on to me from the orofacial pain forefathers and foremothers of old, which is to use one or two fingers for most of these muscles, right? Obviously, if you're taking your hand and doing this on somebody's face, you're probably not going to get much out of that. Also, I don't like to do this spidery thing where you're like crawling around their face. I like to take one or two fingers and just stroke against the predominant muscle fiber direction. So perpendicular to the direction those fibers are going. So for temporalis, we'd be looking at something like that. And for the masseter, we'd be looking at something like that. Go in either direction that you want to. And I kind of think of it as painting. So usually this takes some time to palpate. Like I picture having paint on my fingertips and like I'm trying to paint the whole muscle wherever I'm checking. For some of these muscles, you got to do the pincer grip. So the mid-trapezius would be an example of that. Sternocleidomastoid, another example, right? We palpate both the clavicular and sternal heads and then up along the body of that muscle. When we're palpating that one, you want to make sure you can feel the bulk of that muscle tissue under your fingers. If you're just pinching their skin, that's probably going to hurt anything. But make sure you can feel that muscle all the way up to the mastoid process where you can palpate. Well, how hard do you push? There are some official numbers for this. So the diagnostic criteria for temporomandibular disorders, the DCTMD, the current cookbook that we use for helping us make TMD diagnoses, says at least 1 kilogram of pressure in some areas, temporalis, masseter, and 0.5 kilogram on the lateral pole of the condyle. Now, unless you've got like a postage scale right next to your chair, which you could do if you want to, and you push to calibrate every time, it's not necessarily super practical. So I kind of like to think of moderate pressure. Some individuals will think of how much pressure does it take to blanch a fingertip. Well, if you take your finger and you push on something really hard, it doesn't take much pressure at all. If you push on a fleshier surface like skin and muscle, it takes a little more pressure to blanch a fingertip. So that might be a useful guide for you. But we want to do more than light, less than hard, moderate pressure. As you're charting this, it is helpful to have some kind of a coding system. You can use whatever works for you. But to be able to quickly annotate or have your assistant annotate as you palpate, whether it's non-painful, if there's mild pain or tenderness, pain, severe pain, or pain that's so bad it causes the patient to physically withdraw from you while you are examining them. Muscles that I'll palpate as part of a comprehensive exam include the rhomboids, so between the scapulae there, the levator scap, kind of at that superior corner of the scapula, the traps, the upper trapezius, so that paraspinal area, the splenius capitis, which is just lateral to that. If we're looking kind of behind the sternocleidomastoid, but in front of the paraspinal area, this posterior cervical triangle would include the splenius capitis. C-spine is easy to palpate just by holding your hand horizontally and compressing against the spinous processes of the vertebrae from the big bumpy one, which is C7 or T1, and then just going all the way up to the skull. The occipitalis, of course, is the area superior to the nuchal line in the back of the head. Greater and lesser occipital nerves are often helpful to palpate. Do you guys already know how to locate those? So you'll find the inion, the most prominent point in the back of the head. Put one finger on that. My head's not a good example of this because I got this weird bump on the back of my head, but just pretend like that's not there. You have a finger here and a finger here on the mastoid, and picture a line in between those two. 1/3 of that distance from inion to mastoid is roughly the area of the greater occipital nerve. 2/3 that distance is roughly the area of the lesser occipital nerve. If you kind of feel around there, a lot of times you can elicit a little bit of a sensory change or discomfort, and you kind of know you're in the area of that nerve. Lymph nodes are relatively easy to check as you palpate the sternocleidomastoid and then submandibularly over the thyroid, and then, of course, our masticatory areas, the temporalis, TMJ, which you can palpate. I always palpate that statically with the patient at rest. You can also do dynamic testing, having them do mandibular movements as you apply some pressure. And then the masseter muscle. Intraoral muscles are not listed here, but I do palpate the insertion of the temporalis. Not a difficult one to find in most people. You can just take your finger, move laterally to the plane of occlusion, go back till you hit against that anterior border of the ramus, and then just move your finger upward all the way up to the coronoid process, and that'll all be that temporalis insertion area. Anterior digastrics, just picture those borders of that submental triangle here. Usually I'll do bidigital palpation for this, a finger underneath, a finger inside, and just moving posteriorly on each side. And I do palpate the medial pterygoid, so taking a finger, going just behind the raphe and compressing laterally. And I warn the patient, I'm just going to touch a muscle. It's kind of far back there. Obviously not a real comfortable area. Some people will get a little bit gaggy, but in my experience, people typically can distinguish between muscle pain and just the discomfort of a finger being there, especially if there's a difference from one side to the other. The lateral pterygoid, like Sherwin said, I don't try to palpate that. I'll do that with the dynamic testing that he was talking about. Joint sounds, so fingers here, open, close, side, side. And I don't use a stethoscope. You can do it if you want to, but I will see what I can hear and feel and ask the patient if they hear or feel any sounds. Sometimes they're very subtle. The patient might hear them and you don't. And of course, what kind of sounds, clicking or popping, I don't know that there's a distinction between those terms. You can pick whichever you want. And then crepitus, of course, which we see in those degenerative or arthritic changes, that crunchy, grindy, sandpapery Rice Krispies kind of sound and sensation. All right. Range of motion. So here we're typically measuring how wide can they open without pain. Or if they have constant pain, how wide can they go without making it worse? I am not here to do a product endorsement. You use whatever you want to, okay? But any kind of ruler you can do this with. You can do a disposable ruler. I think these disposable rulers are awfully handy and convenient to use, okay? So we got our maximum opening as well. And our deviations or deflections, right? So in the case of a deviation, they'll veer off to one side, then come back to the middle. A deflection, they'll veer off and just stay there. Do we see any of that as they do their range of motion? Some individuals will routinely do assisted opening. I personally don't do that. I feel like if they can open decently, there's really no need for me to go in there and try to jack them open wider because I might just hurt them. But if their opening is markedly limited, then I will do the old, forefinger on the lower incisors, thumb on the top, give a stretch. What kind of difference do we see? Lateral excursions. As we do lateral excursions and opening, it is important to remember to account for their overbite and for any midline discrepancies. So if somebody's got an overbite of 3 millimeters and they open to 37, their opening is actually 40, right? If somebody's got an open bite of 5 millimeters and they open to 25, their opening is actually 20. With overjet, same thing. You got a 3 millimeter overjet, you protrude and measure it at 6, you've actually got 9. Easy way for me to measure the protrusion and the overjet is just using a UNC probe, just a good old perio probe, I think is perfectly good for that. Sherwin had already mentioned some of the resisted movements. So this is one way to try to test for, try to distinguish muscle versus joint pain and to try to test for lateral pterygoid pain. So it's an isometric exercise, right? We're trying to have them activate their mandibular muscles while moving the mandible, ideally not at all, but in reality as little as possible. So I'll have them do some protrusion, which you can do by supporting the back of the head and placing a hand on the chin, or standing behind the patient, having them brace their head against the headrest and putting both hands against the chin. And I'll just put my hands there. I'll say on the word go, shift your lower jaw straight forward. I'm going to be pulling back against you. Just sustain that forward movement till I say relax. And I'll just say ready, set, go. And off they go. I pull back, hold for a few seconds, and relax. When you do the resisted excursion, same thing. You want to support the contralateral side. Make sure that when you're pushing, you're applying pressure against the mandible itself, the bony areas. You don't want to push on somebody's carotid or something else. That probably wouldn't be good. And when you're doing the resisted excursions, have them do it on their own once, right, before you start pushing against them. A lot of people have some difficulty with those side-to-side movements. You'll ask people to go right to left, and they'll kind of do this with their lips. So sometimes having them hold a mirror will help them, or you can guide them just a little bit till they get the idea. But make sure that when you're telling them to go right or left, they actually are going that way so that they don't go left and you push left at the same time. Now, I'll tell you, these tests are somewhat helpful, but like almost everything else, it's not typically this one piece of golden data that tells you exactly what the problem is. If it's a bit of a complicated picture where it's a little bit more difficult to distinguish whether the primary pain source is muscle or joint, these tests can be helpful, but you really have to take the data and put it all together with everything else, because the body doesn't always play by the rule book. So when you're having them do these resisted excursions, let's say somebody, you're pushing against them, they're shifting their mandible to the right, and they're reporting pain on the left side. Well, if they're reporting pain, you're going to want to ask them where it is. Let's say they point kind of up here, right around that zygomatic area. And you're going to want to ask them as well, is it familiar to you? Same thing with palpation, right? So I'll back up for just a sec. On that palpation exam, again, if we find a tender or a painful spot, like Sherwin said, you're going to want to do a couple things. You'll want to sustain that pressure for several more seconds. And what we're going to want to ask him is a couple things. Does the pain just stay right there where I'm pushing, or does it go anywhere else? And secondly, what's the other thing we want to ask? Is it familiar, right? Is that your pain? Now back to these tests. Again, if they're going to the right, we're resisting them. They're saying pain is on the contralateral side in the area of this zygoma. Well, that would be more consistent with left lateral pterygoid pain. However, it doesn't always play by the rule book. You have to really take the whole picture together with these bits of data. Let's move on past that. Clench tests, same thing. Nice test to do, can be helpful, especially if we're trying to distinguish muscle versus joint, but sometimes the body tries to play tricks on us. So, the classic result here would be you have the patient clench. You want to see, okay, when they're clenching there for a few seconds, just grit down, is there pain? Well, if there is, again, where is it? Is it familiar to them? Take a couple of tongue depressors, put them in there, have them bite down, clench for a few seconds. Same question, is there pain? If there is, where? And is it familiar? And if they had pain both on clenching their teeth and clenching on these sticks, how do they compare? Which one was worse? Was clenching on the sticks the same, or better, or worse than when they were just on their teeth? And then what I like to do is stack them up. Put the tongue blades on top of each other. Some people do this on the canine, some do it on the molars. I do it on the molars. I'll put it back on the second molars, have them bite down, squeeze hard. Same questions. Is there pain? If so, where? Is it familiar? How does it compare to when they were clenching their teeth? And the classic result there would be that if there's pain on the same side on which they are clenching, particularly if the patient then points to a muscle area, that's more consistent with muscle as a primary pain source. If they point to the opposite side, the contralateral side, especially if they're pointing right in front of the ear, that might suggest more likely joint pain. And if you want to, you can dress your patients up like the penguin when you're done, and that's very fun. I don't routinely do this, but you can. It can be helpful, I think, in some situations to load or to distract the joint. So if any of you have had to do that maneuver where you have someone who's having a subluxation or a luxation, they're stuck open, all right, and you have to manipulate them, the hand position is essentially the same. So you would put your thumb back here on or behind those second molars, and your fingers then on the body of the mandible underneath. And if you were going to load the joint, you're trying to load upward, essentially mimicking the direction of the predominant pole of the masseter. If you were to distract the joint, you would then be applying pressure with the thumb and pulling downward, trying to increase that joint space. Of course, intraoral exam will also be part of what we do. So we've mentioned already you need to have a good sense of their dental history, to have palpated some of the intraoral musculature, and to examine the hard and the soft tissues. So do we see any obvious tissue abnormalities, either of the teeth or the soft tissues? Tooth loss, do they have a lot of, for example, attrition? Keeping in mind if they do, we don't know when that happened, right? We're at the train station taking a photo, and we don't know where that train came from, and we don't know where it's going. What we see is what's there right now. So that could have happened 10 years ago, or it might have been happening this morning or last night in their sleep. Probably a better indicator of active parafunction is how the soft tissues look. Do we see a lot of buccal, masticatory trauma or trauma to the lateral tongue or things like that? Occlusion can be helpful to check. I do pretty routinely check it, not because I'm looking for an occlusal explanation for their pain, but because I just want a baseline read. It's quick, it's easy, and sometimes you will see those cases. Some of you have probably encountered this, where someone is reporting, an acute onset of pain concurrent with a loss of occlusal contact on the same side. So what's going on with that? Well, there could be a few explanations for it. One common one is that they just have a lot of fluid in that TMJ. They've got joint effusion. So inflammation has increased the amount of fluid within the joint capsule, and now the teeth, ipsilateral to the pain, won't fully occlude. So in that situation, you look in the mouth, you're not going to see a big occlusal discrepancy. It's not like you're going to be seeing daylight between the teeth. It might look like they have a normal bite. But when you check it, you'll see that they have lost some contact on that side. Best way to check occlusion, in my opinion, shim stock and a hemostat. Articulating paper is not going to be helpful here. It's too thick. And I don't like using those articulating paper forceps, the Miller forceps. I don't know, maybe just the Air Force's Miller forceps are all worn out. But mine just slide right off that shim stock and leave the shim hanging there. So a hemostat and shim stock, a really good way to check. If you see an occlusal discrepancy like that, or the patient reports one, it's important to document that, and then at follow-up, if inflammation is the cause, you should see that resolve as the inflammation calms down. And then given the situation, if you're suspecting an odontogenic or a periodontal pain, those good old classic tests, right? Percussion, palpation, endo-ice, tooth sleuth, probing, those come in pretty handy sometimes. Imaging, depending on the situation. Labs will maybe come up later in this course. There are some situations that you can screen for with that. And then anesthetic can be helpful diagnostically. If you numb up a muscle and the pain goes away, it's a pretty good bet. Muscle's a big cause of that pain. If you do an auriculotemporal nerve block, say extraorally, and the pain goes away, then either it's a joint pain or you just put so much anesthetic in there that you numb the muscles as well. So sometimes anesthetic, in addition to being having some therapeutic benefit, can be diagnostically useful in the moment. Thank you so much for your attention. Sherwin did a great job of staying on time. I did a really bad job staying on time. But I appreciate you hanging in there with me.